Hi everybody, I am Dr. A. Padmanabhan, a senior pediatrician. Today we will see whether a computerized tomography, a CT scan, is routinely required before all lumbar punctures in a case of suspected meningitis. I have found this has become a normal practice in most of the hospitals. Many doctors believe that doing a CT before lumbar puncture is an insurance against subsequent litigation. Let's dwell into the theory behind this and find out whether there is evidence to support this practice. Now let's look at the science behind this. Children with elevated ICP are at risk for cerebral herniation, and that is the whole reason why before lumbar puncture we do a CT, because we look for signs of increased intracranial pressure. But when should you do a CT? A CT of the head should be obtained before LP for all patients when there is a clinical suspicion of increased intracranial pressure. Note the point, clinical suspicion of increased intracranial pressure, only then. When do you suspect there is an increased intracranial pressure? Previously, we were very much worried about papilledema. Whenever we had a case of we were about to do a lumbar puncture for bacterial meningitis, we did the fundus examination. And if the fundus was normal, we went ahead with the lumbar puncture. And we senior pediatricians were quite good at doing the fundus without an ophthalmologist help. Now this is something which I find lacking in the present pediatricians. The other things which you have to think of is altered mental status, focal neurological signs, focal seizures, and risk for brain abscess. Now, altered mental status, I will discuss it later in some detail. And risk of brain abscess is considered in patients who are immunocompromised, or who are having congenital heart disease with right to left shunt, like Fallus tetralogy or transposition of the great vessels. Now, among the focal seizures, 6th and 7th nerve palsies are not considered as focal neurological signs. This is rather surprising to me because we all know that an increased intracranial pressure often produces a 6th nerve palsy and sometimes, rarely, even a 7th nerve palsy. But these are not taken per se as the reason to do a CT and postpone a lumbar puncture. Now coming to altered mental status. Previously this was not given much emphasis, but later on people found out that many children who had no other signs of increased intracranial pressure, who the fundus was also normal, and some of them even the CT normal, when they went ahead with a lumbar puncture, they did have herniation. There's no controversy regarding this, but the controversy is regarding the level of the Glockner scale below which one has to postpone the lumbar puncture. Now, some say below 13, while others say stage of coma. Therefore, only when the patient is comatose, you need postpone the lumbar puncture. Therefore, this is a gray area, but very significant from the practical point of view. Up to date specifies when there is severe mental impairment of consciousness with reduced or fluctuating Glockner scale less than 13 or fall more than 2. Remember, less than 13 or fall more than 2. NICE guidelines bats for a very much lower score, less than 9 or a drop of more than 3. Look at the difference between this, less than 13, 1 and the less than 9. Now our Nelson's textbook of pediatrics now does not discuss this in much detail and just vaguely says, you should not do a lumbar puncture. Now, the Infectious Disease Society of America asks for a Glockner scale less than 12 or less than 12. But remember, it immediately says that an LP can be done safely at lower levels. Therefore, it is suggestion, it is giving a vague guideline. Now, the European Society of Clinical Microbiology says less than 10. Therefore, you have less than 13, less than 12, less than 10, less than 9, comatose. Therefore, this is a real issue, a gray area, and where differing perceptions are there with different clinicians. Now the Swedish guideline is the only guideline which says that altered mental status per se is not an indication for cranial imaging. It has removed it from that. But it also says in comma, don't do LP may be deferred. Therefore, I won't be able to help you further than this. Just to suggest, when you have a altered mental status below 13, below 12 or below, because 13 is given by UpToDate, which is not an international guideline giving organization. Now a word or two about papilledema and acute bacterial meningitis. Now the papilledema takes several days to become apparent. Even the absence of venous pulsation, which is considered the earliest finding, takes a few days. Therefore, it is an uncommon finding. Is an uncommon finding in acute bacterial meningitis. And whenever you find a papilledema, you should do a prompt evaluation for venous sinus occlusion, subdural empyema, or brain abscess. Therefore, it suggests in the settings of a bacterial meningitis, papilledema suggests that there is a complication probably. This is a classical Western teaching, but we have more common tuberculous meningitis in our setup, where the prevalence of papilledema is more. Therefore, it is more important for us to look for signs of papilledema, signs of increased intracranial pressure in all patients before we do a lumbar puncture by doing a fundus examination of the. Now a word or two about children, infants beyond the age of newborn period who have an open fontanelle. Now these children, whenever they develop meningitis, they become drowsy very early on, and it is difficult to look for a Glasgow Coma scale in these children. Now there are no specific recommendation for these children. For decades, we senior pediatricians have been doing lumbar puncture even in drowsy infants with an open fontanelle, even if the fontanelle is tense, without any adverse effects. They have been feeling, and I think this correctly, that an open fontanelle is a safeguard against any coding, any brainstem herniation. But I must tell you, when I looked deep into the literature behind this, I couldn't find many. Probably in this group, a severe mental obtundation to the extent of coma, just like Nelson says in all for all children, it should be considered as an indication for postponement of LP. Therefore, unless the child is very obtunded, probably you can go ahead with a lumbar puncture. But I must tell you that the evidence to support this practice is not there. Now, apart from all this, a recent seizure has some significance. This is not only considered by some to postpone the lumbar puncture, they even consider it as a sign of impending herniation. Therefore, it's almost like a contraindication to do a lumbar puncture immediately. Therefore, when you have a seizure within 30 minutes, particularly a tonic seizure, you better postpone the lumbar puncture. That is, many times we dress up, we prepare the patient, we sedate the child, we are about to do the lumbar puncture, the child throws a convulsion. Some people go ahead and do a lumbar puncture because you're already dead. No, don't do that. What is the reason behind it? Because before a terminal respiratory arrest during brain herniation, many children throw a seizure. That is one reason. And another reason is after a seizure, the level of consciousness is difficult to assess, and seizures themselves cause an increase in intracranial pressure. Now, why exactly a tonic seizure is considered more significant? Because decerebrate posturing may be mistaken by many pediatricians as a tonic seizure. Therefore, whenever you have a convulsion, even if you are well dressed up and you're prepared well to do a lumbar puncture, we postpone it at least by 30 minutes. Now, it's not only for looking for signs of increased intracranial pressure, you do a CT. Sometimes CT throws up a finding which you anticipated or you didn't anticipate, like a symptomatic hydrocephalus, subdural empyema, or a cerebral abscess, which might require a prompt neurosurgical intervention. And contrast-enhanced CT scan may also detect complications like venous thrombosis, infarction, and ventriculitis. An ependymal enhancement can be seen in contrast enhanced CT scan, which may be a telltale evidence of meningitis. Now, CT or MRI may throw up a finding of a mass lesion also. This is less common, this is rare if you have made a complete physical examination. After discussing so much theory, let's see how we practice, or we put these things into practice. Let's see whether we do CT routinely, and if we don't, we postpone the CT. If we don't do the CT, what is the advantages? If we do the CT scan and postpone the lumbar puncture, what are the advantages and disadvantages? And how should we be practicing? Now, what is the plan? We are discussing practice, and surprisingly, we are going to plan B. Why are we going to plan B? I will come to that later. In plan B, the CT is planned and the LP is deferred. Therefore, we are going to do a CT, therefore the lumbar puncture is postponed. What do you have to do then? Now, immediately you can't delay the treatment because suspected pyogenic meningitis is a medical emergency. Therefore, put in an IV needle and collect a blood culture before you give the antibiotic. This is very crucial, especially in infants. But then you have to give empirical antibiotic. There comes the problem. The commonly used empiric regime is for infants and children. You should cover Streptococcus pneumonia or this pneumococcus, meningococci, and H influenza type B. It should not only covered by pneumococci, it should also covered for cephalosporin resistant pneumococci because you don't know what you're dealing with. Some people also give cover for herpes simplex with acyclovir. But what is appropriate antibiotic to give? Usually people give a cocktail of vancomycin, ceftriaxone or cefotaxime, and sometimes acyclovir also. Now remember, I find that many pediatricians are quite comfortable giving ceftriaxone alone here. But I'd like to warn you, the pneumococci is resistant to cephalosporin, you will be delaying the treatment. Now, adding acyclovir is when you are suspecting herpes simplex encephalitis, you may have to add acyclovir. But you remember, this is a dangerous cocktail. Vancomycin plus acyclovir are both renotoxic, and especially in infants, if they can lead on to problems of renal shutdown. Another issue is now it has become standard practice to give steroids to prevent complications like hear deafness. Now this is routinely given in diagnosed cases of H influenza meningitis, proved in H influenza meningitis. But when you are giving empirically antibiotic, how are you to know that it is H influenza? These are the problems of giving empirical antibiotic. And whenever you give empirical dexamethasone and whenever you give empirical steroids, it has to be given before or at the time of the first IV antibiotic. Therefore, some pediatricians do give it in all children empirically who are unimmunized. On immunized children, they don't give it. Now, a normal CT does not absolutely exclude the presence of an increased intracranial pressure, or elevated ICP will not develop in the later hours. Therefore, after you do a CT, you may find that it may get reported after a few hours, and then the intracranial pressure can increase ICT can develop over a period of time. Sometimes a normal CT can occur even when there is an elevated ICP intracranial pressure. Therefore, it is important that you do a lumbar puncture within 6 hours of a normal CT, and if there are no other contraindications. These are practical points which I am telling you. Another thing I didn't miss telling you is, when you give dexamethasone and vancomycin together, the vancomycin does not penetrate the blood-brain barrier well. Therefore, because it requires an inflamed meninges to cross the blood-brain barrier. Therefore, many people when they give dexamethasone to prevent deafness, they give rifampicin instead of vancomycin. Therefore, what it all shows is that once you defer a lumbar puncture, the management gets complicated. Now, another reason why you should not do a lumbar puncture even when the CT is normal, when there are signs of impending herniation. The signs of a deteriorating level of consciousness, particularly to a Glasgow coma scale less than 11. This is a very important point to note, that if there is a Glasgow coma scale less than 11, even if the CT is normal, probably you should not be doing a LP immediately. Or there are brainstem signs like pupillary changes, posturing or irregular respiration, and a very recent seizure. If impending herniation, no lumbar puncture, even if the CT is normal. Now, if the CT, now you have done a CT and it does not show signs of increased intracranial pressure, we normally go ahead and do a lumbar puncture. But they still emphasize that you have to do you have to do a relative risk of performing an LP has to be weighed against the potential benefit, diagnosis of meningitis due to an unusual or difficult to treat pathogen. A risk-benefit ratio, probably risk-benefit should have to be done here. Probably it is time to take a second opinion before you do a lumbar puncture after a CT. But this is Western literature again, and since we have TBM as one, and which can only be diagnosed by a lumbar puncture, probably we would err more on doing a lumbar puncture after doing a CT if there are no absolute. One issue, one major issue which I have in practicing pediatrics in the way to do routine CT scan before LP is that we sometimes miss the exact bacterial cause of meningitis and the antibiotic susceptibilities. Now, if you give empirical antibiotic, what happens is the CSF can become sterile within 2 hours in meningococcal meningitis and within 6 hours in pneumococcal meningitis. And also the cellular changes like increased neutrophils and also the biochemical changes like the low blood sugar and the high protein may reverse in 2 to 3 days time. Therefore, there is a price to pay when you postpone. Now, another issue, you might think that you might compensate by doing a rapid bacterial antigen test or a polymerase chain reaction of CSF and blood. This has been emphasized by the IAP webinar recently. But somehow I find that these tests are really costly, not easily available in Indian conditions. And even in the West and in the Gulf where I practice, usually the blood cultures and CSF cultures and CSF microscopy is considered superior. But we do bacterial antigen both in the blood and CSF. I have mentioned before, TBM, missing TBM is a major issue as far as we are concerned. This is in spite of the fact that the CT scan is 89% sensitive for the findings of TBM, including basal enhancement, infarction, and hydrocephalus. Therefore, CT scan will give you telltale evidence of tuberculous meningitis. But even then, if you postpone the LP, sometimes it can be a problem. Well, so far we have been always talking about CT. A word or two about MRI. Why is CT preferred? CT is preferred over MRI in an emergency as it's more widely available, less costly, and may not need anesthesia and takes less time. Now you can do an CT with probably by sedating the child with a chloral hydrate and if most by an IV midazolam. But on the other hand, if you want to do an MRI, most probably you will require a general anesthesia because it takes much more time. Now, enhancement of the meninges is seen in contrast enhanced CT scan and MRI in cases of bacterial meningitis. However, meningeal enhancement is a non-specific finding. Therefore, you can find meningeal enhancement in both, but better seen in an MRI. And here is an MRI which is T1 weighted MRI which shows enhancement of the left-sided dural enhancement, that's patchy meningitis. But this is not diagnostic of meningitis, but it gives telltale evidence about that. Now, apart from the fact that MRI is superior to CT scan in showing telltale evidence of meningitis, like meningeal inflammation, and it shows better the complication. In viral encephalitis, it has special significance. There are definite signs which point to an herpes simplex encephalitis or Japanese encephalitis, and our pediatric neurologist colleagues will be able to help you out. Therefore, there are certain advantages of MRI over CT. Therefore, when do we do an MRI instead of a CT? There's a very small place in meningitis. In situations where the LP is postponed for many hours or days due to cardiopulmonary instability, severe bleeding diathesis, or the assessment of his risk of LP was outweighed the benefit, and we have postponed the LP for 3 or 4 days, then probably at that time, when you do an imaging, MRI may be preferred. Some people do an MRI once the patient is stable after a CT routinely if we have some clinical suspicion. Now, even if you delay for a few days, remember up to 7 days, a herpes simplex virus polymerase chain reaction can be positive in an CSF. Therefore, even if you have not done a lumbar puncture on the 3rd or 4th day, you can do an MRI or a CT and subsequently do polymerase chain reaction test for herpes simplex in the CSF. And now all these decisions should be better done by a team of pediatric neurologists, intensivists and radiologists. And I have already emphasized that. Therefore, now we come to plan A. Now this is what we should aim at. The time-tested management of children with short history of headache, fever, vomiting, with meningeal signs, with normal fundus, and with no clinical suspicion of increased intracranial pressure should be by prompt NP without a preceding CT scan. And this is because we want to give early appropriate antibiotic therapy, which should not be complicated by empirical therapy, etc. And this is one of the most gratifying treatment options in clinical pediatrics. Therefore, routine CT should not be practiced. Now again, obtaining a CT, if you want to emphasize it in a different way, obtaining a CT without an indication is of no clinical benefit, is costly, delays diagnosis and therapy, and can impact outcome in patient with meningitis. The other factor we often consider is radiation exposure. So to put everything in a nutshell, when you have a suspected meningitis, you look for altered mental status, focal neurological signs, papilledema, focal seizures, or if there is a risk of brain abscess. Now, if none of them are present, you go for plan A, which is lumbar puncture without CT scan. And if any one of the above is positive, yes, any one of the above is yes, any one of those questions are yes, then you go for plan B, which requires a blood culture to be taken immediately along with other investigations, empirical antibiotic, CT scan, and lumbar puncture if no contraindications are there. Now, what are the take-home messages I have to give you? The first thing is CT is not required before all lumbar punctures in suspected meningitis, as it delays the early antibiotic administration. Therefore, routine CT, as is often practiced nowadays, is not ethically or scientifically correct. Empirical antibiotics, as we have already seen, can complicate the management subsequently. A low Glasgow Coma scale alone can be a sign of increased intracranial pressure, but what is the level below which one has to not do a CT or postpone a CT is something which is where there's no agreement on. Probably below 11, definitely it's a contraindication because it's taken as a sign of impending herniation. Even with a normal CT, the child can herniate, especially if there are any signs of impending herniation. This message is very important for people who think that a normal CT is an insurance against litigation. Now, I am Dr. A. Padmanabhan and I blog on pediatric-end-theory-practice.wordprocess.com. I blog on all these subjects. If you read the blog rather than watch the video, you will find all the reference there. And this is a pediatric clinical decision aid made by what is what I am aiming at. It is an evidence-based, up-to-date pediatric practice. I dissect one clinically relevant bedside issue, only one aspect of a clinically relevant bedside issue. Like today, I discussed about CT before lumbar puncture. I hope it's useful to you. And I am Dr. A. Padmanabhan, pediatrician with more than 35 years of experience, out of which the first 12 was in India, both in a primary and in a teaching institution, in the private as well as in the government service. Then I had about 26 years experience abroad again and again in tertiary care as well as secondary care in teaching and non-teaching institutions. Thank you for listening to me.